Visible now.
Yes. So good afternoon, everybody. And again, thank you for having me today. Today, I was asked to present highlighting oropharyngeal dysphagia from basics to clinical practice. And before I start, I would like to mention, as Dr. Afriel said, that I'm from Alexandria, Egypt, and it's a beautiful city on the Mediterranean Sea. It's pretty hot now in Alexandria, and I hope this presentation will be a good way to spend the afternoon together. This is my Otorhinolaryngology department at the Faculty of Medicine, Alexandria University, and all of my dear professors had a great impact on my career and on my life. This is my phoniatrics unit with my colleagues and my residents, and this is my disclosure as well. I got to know from Dr. Friel that the phoniatrics subspecialty is not very well known in the Gulf area, and maybe I can shed the light on this type of practice in today's presentation. So the phoniatrician is a medical doctor specialized in the holistic management of swallowing, voice, communication, and pediatric hearing disorders. The phoniatrician closely cooperates with the speech-language pathologists in the field of behavioral treatment. We are highly connected to the Union of European Phoniatricians, and from the name European, but actually it is a diverse population. We have phoniatricians from all over the world. And I'm currently an active member of the Swallowing Committee of the Union of the European Phoniatricians with the rest of my colleagues. This was our last meeting in the Czech Republic in June 2025. And as I mentioned, we are very interested in the different fields of voice, swallowing, speech and language disorders. As you can see, this is the distribution of phoniatricians all over the world. And we are mainly located in Europe and in Africa and some parts of North Africa, some in the Latin America, but to a lesser extent in Asia. And as I mentioned, we are following the European paradigm of phoniatricians, and which is mainly located in Europe. So as we believe that the swallowing disorders and the management of swallowing disorders is a multidisciplinary and a multi-professional teamwork, we had a position statement published in the Dysphagia in 2023. And in this position statement, the UEP mentioned that adequate management of the dysphagic patient requires a holistic, multidisciplinary, and multi-professional team. That includes medical specialties as phoniatricians, otorhinolaryngologists, speech-language pathologists, gastroenterologists, neurologists, and ICU physicians, as well as therapeutic disciplines, including the speech-language pathologists, the dietologists, and physical therapists. And the conclusion of this position statement was that task distribution within the dysphagia team mandates and must be viewed dynamically and is determined by historical country-specific developments of medical and therapeutic disciplines and legal regulations. So who should perform fees is only determined by the qualification-specific considerations rather than professional policy. So it's not only about who performs the fees or who performs the swallowing assessment. This depends totally on your country's regulations and on the experience that you have and that you are a trained professional in dealing with these patients. So without further ado, this is what I'm going to go through in my presentation. I will give a quick introduction about swallowing disorders or oropharyngeal dysphagia. We will discuss the etiology, the symptoms and complications. We will move on to the diagnosis and management strategies. And then I'm going to wrap it up by some case presentations and our conclusion. So we all know that swallowing is mediated by three phases: the oral phase, which includes the oral preparation of the bolus and propelling the bolus backward to trigger the swallow reflex and starting the pharyngeal phase of the swallow, and it is usually ended by the esophageal phase of the swallow. This is all presented and in the following schematic representation of the neurophysiologic circuit of swallowing function published in 2023. And as you can see that it's not only mediated by the central pattern generator from the nucleus tractus solitarius and the nucleus ambiguous, but as well as mediated and controlled and coordinated by cortical and subcortical areas. So oropharyngeal dysphagia is a clinical symptom, and it is the difficulty to effectively move the alimentary bolus from the mouth to the esophagus. It affects about 7% of the population. Among the elderly, the prevalence is estimated at 30 to 40%, and about 80% of oropharyngeal dysphagia cases are caused by neurological diseases. So as I mentioned that we deal with a lot of specialties, and we are really lucky to have that, which makes our specialty really diverse. And we receive a lot of patients from our neurology colleagues suffering from dysphagia after cerebrovascular strokes, or with patients having neurodegenerative diseases like Parkinson's, amyotrophic lateral sclerosis, and multiple sclerosis. Other patients from the neurosurgery, as those suffering from brain tumors, patients who have a primary damage to the neuromuscular junction like myasthenia gravis, and those who have primary muscle damage like myopathies. We deal a lot with patients in the ICU who suffer from post-extubation dysphagia. Also patients that have changes after head and neck surgeries, changes after cancer surgery, especially patients with hemiglossectomies or hemilaryngectomies, and patients who receive radiotherapy for the head and neck usually come to us suffering from oropharyngeal dysphagia as well. Other specialties like the geriatric medicine who send us a lot of cases with presbyophagia or Alzheimer's and dementia, and patients suffering from gastroesophageal reflux disease. So the symptoms are really variable. We can receive a patient with a very early symptom, or we can receive a patient with a complication. For example, patients having drooling with oral management of secretions or bolus, patients with ineffective chewing or an extra time needed to chew or swallow, patients with oral residue, patients who have inability to maintain lip closure leading to anterior loss of bolus, patients with nasal regurgitation, and we see that a lot with cases of myasthenia gravis, complaints of food sticking or globus sensation, changes in the vocal quality in the form of wet or gurgly sounding voice, frequent coughing or throat clearing, and avoidance of certain foods or drinks. And we may also see complications like patients with weight loss, malnutrition, or dehydration, or acute or recurring aspiration pneumonia. So the assessment of a patient with oropharyngeal dysphagia is really important, and it has to pass by several levels. So our first level would be the screening, and then we move on to the clinical swallowing assessment, or the so-called clinical swallowing evaluation. The last thing would be the instrumental assessment using either the fiber optic or the flexible endoscopic evaluation of swallowing, the videofluoroscopic swallow study, or the high resolution impedance manometry, the first two being the gold standard in our case. So the screening protocol is really important, and we should not skip this stage, where we first administer an interview or a questionnaire that addresses the patient's perception of and or concern with swallowing functions. Then we can observe the patient during mealtime, and then we administer a standardized screening protocol, for example, like the water swallow test, the 3-ounce water swallow test. And then after we finish the screening, we start to recommend additional assessment. The clinical swallowing assessment is very important and should not be skipped, where the patient and caregiver interview allows us to gather information about the patient's history with swallowing difficulties. Is this the first time for the patient to suffer, or did he have previously a problem, including any reported symptoms or concerns? Oral motor and sensory examination is very important. We assess the structure and the function of the mouth, the lips, the tongue, the jaw, and the palate, including strength, range of motion, and sensation, as well as pharyngeal and laryngeal assessment, where we evaluate the patient's ability to initiate a swallow, the movement of the larynx, and the presence of any abnormal secretions of residue. Here, it's worth mentioning that we need to perform adequate cranial nerve evaluation and assessment. Trial swallows are given as well during the clinical swallowing evaluation, and we observe the patient's ability to swallow various consistencies of food and liquids, and we look for signs of aspiration of food or liquid entering the airway or residue. Voice assessment is very important, especially in cases who are in the ICU. We evaluate the voice quality before and after swallowing, as changes in voice can indicate aspiration or other issues. So if we have a patient who has a wet and gurgly voice, it's really worth mentioning that here we should do a more detailed assessment. Then we move on to the third level, which is the instrumental evaluation. So instrumental evaluation gives us an idea about the structure and the dynamics as well. So, and we do that in a structured way. So, are all patients indicated for an instrumental assessment? Actually, we have some contraindications for instrumental examination, which includes if the patient is not medically stable enough to participate in the procedure. I cannot perform instrumental assessment to a patient who is comatose, and he will not benefit from the instrumental evaluation I'm going to do. The patient, if the patient is severely agitated or unable to remain alert or unable to follow simple commands, and if the patient has anatomical deviations, if I know that the patient has an abnormality in the nose, I cannot insert a nasopharyngoscope. If I have a patient with a problem in the head and neck or the digestive tract, that preclude the use of barium, for example, in the videofluoroscopic swallow study. So let's move on to our first and our, maybe it's the most used technique, the flexible endoscopic evaluation of swallowing. As you can see, we are going to move with the levels of the assessment. So we start by, I'll give you a quick idea about the history of the fees. And as you know, the earliest description of fees in the literature dates back to 1988 by our dear Professor Dr. Susan Langmore and the ENT specialist Nels Olsen. I had the pleasure to meet Dr. Langmore back in, I think, 2017 for a conference in Spain, and it was a very interesting workshop that she conducted. Back then, the technology allowed only the examiner to look through an eye hole, and the exam was not recorded using a camera. The examiner had to remember what they saw to prepare a report. Luckily, with technological advances, this procedure has drastically improved. And as you can see now, we have cameras, we have monitors, and we have the distal chip endoscopes that made life much, much easier for us. The equipment that we need would be any system that you have. Regardless of the company, any system that you have will do the job. So we actually, this is a picture from my unit that we have two systems. We have the stationary system for the outpatient setting. If your patient is ambulatory and is coming to you, we can use this. And we also have the portable mobile unit for inpatient settings containing a lightweight component on a cart with wheels. And as you can see from the technology, we now have smaller devices than this one even that we can put in a bag and go to our patient, especially if he's in the ICU or non-ambulatory. The nasopharyngeal laryngoscope that we're going to use has some important specifications, like the scope angle of view should be 80 to 90 degrees, the deflection 120 to 180 degrees. The scope diameter, we have the very small diameter 2.4 for the pediatric population up to the 3.8 millimeter diameter. And we have the camera quality that could be digital or analog. The camera could be either connected to the scope with each exam, and it can also be embedded into the scope. It's also worth mentioning that we need protective equipment, gloves, masks, and other personal protective equipment. This should be worn by the clinician, and especially during the period of the COVID, we made it very, very strict with our residents and ourselves that we should wear our PPE during the evaluation. So what are we going to do now that we know the history and now we know the equipment and we have it? These are the procedural components. As you all know, that FEES is really well tolerated and is easy to perform, but it can result in some controlled complications such as discomfort, gagging or vomiting, a vasovagal syncope, anterior or posterior epistaxis, or sometimes very, very rarely laryngospasm. But we need to know what could go wrong in order to be able to deal with it. The second step would be the patient preparation. So before starting the examination procedure, we need to take the patient consent. We explain the exam protocol and the process to the patient, the caregivers, or the responsible parties present. Then we can administer topical anesthesia or nasal decongestant if indicated, and we prepare the food and the liquid to be used for test swallows, and we position the patient so that both the patient and the examiner can see a monitor, and we prefer that the patient is seated 90 degrees. We start to prepare the food consistencies, and we usually follow the International Dysphagia Diet Standardization Initiative. If you're familiar with this, it's a very good way to classify drinks and foods, and we have 7 levels, as you can see, and it provides a common terminology to describe food textures and drink thickness between clinicians. Then we start inserting the endoscope gently into the nasal cavity, advancing it along the floor of the mouth. And we guide the endoscope to a position just above the epiglottis, providing a clear view of the pharynx and the larynx. We ensure visualization of critical structures, starting from the true vocal fold and ending by the tongue base. The flexible endoscope with the tip located just inferior to the velum behind the uvula, and the tip of the flexible endoscope is deflected to obtain this view. So the FEAST protocol is really important and is divided into 2 stages. First, the pre-swallowing tasks and observations. Clinical and anatomical observation of the hypopharynx is very important. We observe all the anatomic structures, the mucosal irregularities, and the presence of foreign bodies in the nasal passage or the pharynx and the larynx. We then comment on the secretions. Before we introduce any food or fluid, we observe the presence and location of secretions and the patient's response, such as coughing, throat clearing, and swallowing. And we note the secretions in the laryngeal inlet, like in this patient. And we use some scales to stage the amount of secretions. I usually prefer the Murray scale, which is a scale from 0 to 3 to indicate the location of the secretions. And after that being done, we start to count the number of spontaneous swallows during 1 minute. It's supposed to be more than 1 swallow. And some studies performed on counting the number of swallows found that if the patient swallows less than 1 time in a minute, then this patient is at higher risk of aspiration and maybe aspiration pneumonia. The movement of structures are very important. We observe the presence of movement abnormalities at rest. For example, the tremors, myoclonus of structures of the base of the tongue, the pharyngeal walls, arytenoids, and the velum. The patient will perform tasks that activate specific structural movements, and we note the symmetry, the speed, the coordination, and the extent of movement, as well as the epiglottic retroflexion, which is seen during swallowing. We ask the patient to swallow his own saliva, and we assess the inversion and return to the upright position immediately after the swallow. After that, we start the bolus presentations, and it has been recommended to start with an ice chip protocol, which can be used if foods and liquids are not initially appropriate in severe dysphagia, or if the patient has not swallowed orally in several weeks, he is MPO, and if the patient has some reduced level of alertness and diminished airway reflexes and motor function, and then we can move on to introduction of foods. We start by the safest consistency first, and we give different consistencies and volumes of liquid, puree, and solid boluses. And we leave the most challenging to be presented at last. So how many boluses do we give the patients? Usually, we start by minimally 3 boluses within each consistency, so that you can get a good idea about the mechanism of swallowing and the protective mechanisms of the patient. So after we introduce the bolus, we use the penetration aspiration scale. It is widely used to evaluate episodes of penetration and or aspiration and the patient's reactions to them. And we start by 1, where there is no penetration or aspiration, and the level 8, where the contrast passes the glottis, and we find visible subglottic residue. and an absence of the patient response. That's the one that we call silent aspiration. The bolus presentation as well, we need to scale or score the bolus residue, and we have a lot of scores: the pooling score or the P score, the Boston residue and clearance scale, or the Yale pharyngeal residue severity rating scale. And this is the most commonly used, and I really like this one because it gives us 5 levels at both the level of the vallecula and the level of the piriforms. So if suspected that the severity of dysphagia has not been adequately revealed with the administration of single boluses, then use consecutive sips or bites or other conditions that are more difficult, like larger volumes, mixed consistencies, and increase in the pace of food presentation or self-administered presentations. You need to be more challenging for the patient. You can't just give one bolus in each consistency and you say, well, he is safe swallower. This will not give you the exact idea or the whole picture of your patient. So if aspiration risk is suspected but was not detected in the usual deliveries, repeated presentations of the same volume and consistency. In this study in 2014, they mentioned that we can give up to 10 trials of the same volume and consistency for detection of aspiration. It's really important to evaluate the sensory function in your patient. So this is usually inferred from the patient's response, the gagging, the coughing, the flinching, to the presence of bolus residues in the pharynx, and or to the penetrated or aspirated material. But if uncertain about the sensory function, we can do additional formal laryngeal sensory testing is indicated. And we usually leave that to the end after the administration of boluses so that you will not irritate your patients. So what we usually do is the fiber optic endoscopic evaluation of swallowing with sensory testing to elicit the laryngeal adductor reflex. This is the most common method used, and it is described almost in 90% of the studies, where the laryngeal adductor reflex, which is the brief closure of the true vocal folds, it is elicited using either an air pulse stimulus, but this needs a special equipment which is no longer being produced, or as simply as touching the arytenoids with the tip of the endoscope. It's the advantage of eliciting this laryngeal adductor reflex is that it's being an involuntary reflex. We can perform this even in patients with cognitive deficits or aphasia who are not capable of communicating properly with us. It's really important to mention that we should give the patient, our patient, the heads up. We tell him that we're going to touch something in his throat. So is that all about the FEAST protocol? Actually not. It's not only about is the patient penetrating, is the patient aspirating, is there some residue? It's a very good protocol and it's a very good assessment tool to evaluate the effect of intervention. You need to come out with certain recommendations from your evaluation. So we evaluate the effect of specific interventions like the posture changes, bolus modification, or sensory enhancement. So our second go-to tool is the videofluoroscopic swallowing study. And in this procedure, it is a radiographic procedure that provides direct dynamic view of the oral, pharyngeal, and upper esophageal function. And as we can see, this is the patient in the lateral view, and the first one was the normal swallow study, videofluoroscopic swallow study, and the second one, as we can see, the aspiration in the airway. Videofluoroscopic swallow study originated from the barium swallow study. Jerry Logman in 1983 described modifying the barium swallow in order to objectively assess the oral and pharyngeal phases of swallowing. Videofluoroscopy is performed by phoniatrician or a speech-language pathologist and a medical radiological technologist with or without the presence of a radiologist. It depends on the rules of your facility and of your country. We provide the patient with various consistencies of food and liquid mixed with barium that allows the bolus to be visualized in real time. As you can see, we take two views, the anteroposterior view and the lateral view. It's really beneficial in identifying whether aspiration has occurred in the assessment of amount and timing of aspiration, the assessment of the anatomy and the pathophysiology of swallow function in the oral and pharyngeal phases, and the influence of compensatory strategies and diet changes. Establishing parameters to reduce radiation during videofluoroscopy include keeping the exposure time brief. Usually in studies, they mention that a duration of 2.5 up to 3.7 minutes are just more than enough to obtain the information you need, and you should not exceed the amount of 3.7 minutes per patient. We use lead aprons and other shielding, and we maximize the distance from the source of radiation. There are some advantages for videofluoroscopy over FEES, which is the real-time visualization of the bolus from the oral to the esophageal cavity, as well as the visualization of the pharyngo-esophageal segment, the disadvantages of which will include the radiation exposure, of course, which sometimes overcome by limiting the number of observations and follow-up and switching off the device in between the swallows, as well as the need for an X-ray unit, which makes it unsuitable as a bedside examination. So you have to have a patient who can come to you in the radiology department. So a quick idea about the high resolution impedance manometry. There are a lot of diglotologists starting to perform this, and gastroenterologists as well as phoniatricians. Actually, in my university, we have it done at the gastroenterology department. It is performed to assess the motor function of the esophagus if we're suspecting motility disorder. It is a catheter that has several electronic pressure probes. It is passed into the stomach to measure the esophageal contractions and to define the upper and lower esophageal responses to swallowing. This is the device, and this is the catheter, and this is the graph that comes out of the system. As you can see, it has no automatic analysis program, so it is operator dependent. So if you're a good reader of the graph that came out to you, then you will give adequate results. Improper placement of the manometric catheter, of course, is one of the limitations. It could not detect aspiration, and it could not represent the degree of the pharyngeal residue. So as we went through, we got to know the different tools to assess a case with oropharyngeal dysphagia. So what are we going to do? How are we going to manage this patient? After, as we mentioned, the swallowing evaluation, we are always asked, we need to give a decision about the patient's potential for functional improvement of the swallow disorder. Is this disorder going to improve or not? And the safety in the swallowing of liquids and solid food. Will the patient be able to have oral intake even if one safe consistency is possible? Our decision is usually based on the physiologic nature of the disorder and the ability to alter the dysfunction. And we alter the dysfunction by volume or consistency change, by postural adjustment, or by rehabilitation strategies. So the primary goal of dysphagia intervention would be to safely support adequate nutrition and hydration, and to try to return to safe and efficient oral intake. We determine the optimum feeding method and technique to maximize swallowing safety and feeding efficiency, to minimize the risk of pulmonary complications, reduce the patient and caregiver burden while maximizing the patient's quality of life, and develop treatment plans to improve safety and efficiency of the swallow. This is done by a big team of professionals, starting by the primary care physician and ending by the primary caregiver, who is usually the one left with the patient. So we have different management strategies, either compensatory to minimize the symptoms and adverse consequences of dysphagia. They do not change the swallowing physiology, and this is important to highlight, or rehabilitative techniques that include concerted training to optimize the normal swallowing physiology. So swallowing maneuvers may include maneuvers to improve the safety or efficiency of swallowing function. They are used as short-term compensations, for example, the supraglottic swallow to reduce the risk of aspiration, or the effortful swallow to decrease the amount of residue. Postural changes like body posture changes or head posture changes that will lead to alteration of the speed or the flow direction of the bolus, that will lead to reduction of aspiration or residue. For example, we have the head flexion or the chin tuck, or the head rotation or head turn that aims to reduce the aspiration and to reduce the amount of residue. Dietary modifications to modify the consistency of food and or liquid in order to improve the safety and or ease of oral consumption and thus maintain safe and adequate oral intake. As you can see, we have a lot of thickeners on the market and costs and tools to make the food look more appealing to our patient in order to improve their adherence to the consistencies that we recommend. But it's worth mentioning here that as the diet is modified with alteration in its taste, texture, and appearance, this could decrease the acceptability and the adherence to the recommended consistencies, and maybe malnutrition will set in. The rehabilitative interventions could be achieved by either highly structured programs like the Laryngology Dysphagia Therapy Program or individual clinician-designed treatment plans. It's worth mentioning here, and it's important to highlight that the technology in dysphagia is very important, like the neuromuscular electrical stimulation or the deep pharyngeal electrical stimulation, as well as the transcranial magnetic stimulation and the transcranial direct current stimulation. The modalities, whether central or peripheral stimulation strategies, aim at enhancing functional recovery by promoting plastic changes of the cortical swallowing network. And this reminds us of the first slide in this presentation with the cortical and subcortical control of the swallowing function. The nutritional support is very important as well. Enteral nutrition, whether nasogastric tube, if a short period of time is expected from 4 to 6 weeks, and when there is no risk of birth, or resorting to the percutaneous endoscopic gastrostomy if we're not expecting that the patient will recover within the 4 or 6 weeks, or if we have a chronic or a progressive disease, as the patients with amyotrophic lateral sclerosis, because we know that this disorder is progressive and maybe the patient will worsen across the time. Nutritional support with oral nutritional supplements, its main goal is to increase the total nutrient consumption, to maintain or recover nutritional status, maintain or improve quality of life, and reduce morbidity and mortality. And by that, I come to the end of the first part of my presentation. This is a very nice picture from Egypt's north coast. And so let's start with our, I'm still sharing my screen, right?
Yes.
Yes, okay. So let's move on with our first case presentation. So we received this gentleman. He was a 74-year-old male patient. He had a history of coronary artery disease, cardiomyopathy with left ventricular ejection fraction of 20 to 25%. He was an active smoker, had diabetes and hypertension. He was transferred to the ICU suffering from cardiogenic shock. The patient had presented with dyspnea requiring intubation for respiratory failure. The patient was then seen by the speech-language pathology service for 3 consecutive assessments, 1 month after he has been, 1 week after he has been extubated. The initial assessments, as you can see here, showed a lot of residue, especially in the laryngeal inlet as well. And as you can see here, aspiration with thin fluids was documented. The report that we received from, he was actually admitted, he was visiting his children in the United States, and this is the report that they sent us. And as the prognosis was unclear, as the etiology appeared to be greater than the decoding given lack of improvement on serial exams, the patient was recommended to have a PEG and stay oral until speech swallowing rehabilitation was performed. So when we received our patient, we started swallowing rehabilitation with maneuvers and techniques and thermotactile stimulation. And as you can see here, of course, this is only a very, very small portion of the swallow study. As I mentioned, a swallow study average would take like 9 to 11 minutes. And this is only a small portion of it. We have been seeing this patient for 3 consecutive months, and by the end of the 3rd month, this is what we could find. And with different consistency, as you can see, the patient swallowed safely and efficiently without the presence of any residue and without the presence of any penetration or aspiration with different consistency. So our take-home message from this case presentation is, as you have seen, the speech pathologists were not sure what is the exact etiology of this problem, and they saw that it is greater than what they expected in his condition, and they didn't know when will he be able to maintain oral feeding safely and efficiently. So it was very easy. They went to a PEG, and as you can see, after therapy, the patient was able to return to complete oral feeding without any thickeners, without any diet modifications, and the PEG was closed, and he is eating orally in a normal way. So having a PEG is not a major problem, as sometimes being expected or feared from. It's a good way to have a patient who is cooperative during therapy and not going around with a nasogastric tube in his nose. So our second patient, let me tell you about her. She's a 19-year-old female patient. She came to my clinic complaining from the inability to eat, especially with solid foods, in spite of good appetite. She mentioned that she wants to eat, but she eats a couple or 3 bites, and then she can't continue her meal. And she mentioned that this has been the case since early childhood, when she started to figure things out by the age of 11 or 12, and she started complaining to her parents, who were always thinking that maybe she is she's being spoiled, maybe she doesn't want to eat. But actually, when I saw the girl, I acknowledged her problem, and I asked her if she can perform a swallow study with me, and we can see what is happening. And when we started giving her different boluses and different consistencies for a 19-year-old patient, girl who doesn't have any central problems and any history of diseases or illnesses, when you see this amount of residue present and over the different swallows, you can see it starting to penetrate. You start wondering, what could it be? My first go-to was, I believe that this girl has something in her esophagus. So I recommended that she would visit a colleague in the gastroenterology to perform an upper GI endoscope. And this was the result. The esophagus had normal looking mucosa up to 20 centimeters from the incisors, and an esophageal web was noted, and it required balloon dilatation on several settings, and in order to be able to dilate this esophageal web. The mother called me a few months later, mentioning that the girl started to eat better, and she feels that she can finish her meals now with her friends, and she is no longer embarrassed when she goes out with her friends and her colleagues. So our take-home message as well, as we mentioned, that management of swallowing disorders is a multidisciplinary team. It's very important to acknowledge what the patient mentioned, and not only say, well, maybe she is just being this is exaggerating about her condition or something. We need to acknowledge the patient's complaint and work your way systematically to reach the proper diagnosis and reach out to different specialties as well. I'm moving on to my third case, who is a 34-year-old male patient. He had an operated right parapharyngeal vagal schwannoma. He presented with aspiration, especially with fluids, as well as a feeling of food sticking in his throat. And as you can see, this was our first endoscopic evaluation for this patient. As you can see, the lot of residue in the postcricoid area, and especially on the right piriform, the attack of penetration that happened, as well as the vocal fold immobility, and the little bit of bowing in the right vocal fold as well. So therapy was given as well in the form of swallowing exercises, as well as maneuvers, including a supraglottic swallow to protect the airway. And within 3 weeks, the patient started to move on to a better diet. And after almost 1 month or 1.5 months this was the patient's second evaluation. And as you can see, the amount of residue is markedly reduced and no penetration or aspiration in this patient. So the swallowing exercises do minimize complications and can help your patient get back to oral feeding as soon as possible. And dealing with our colleagues in the laryngology and head and neck surgery, it's really important to counsel the patient about what is going to happen, what he is going to face after the surgical intervention, so that he is ready to cooperate and participate in the swallowing rehabilitation after that. So I have another case. It's a really interesting one. I was discussing with Dr. Feriel the other day, and we have this 72-year-old male patient. He came to me from a neighboring country. He was complaining from nasal tone of speech, nasal regurgitation of fluid, change of voice, bilateral ptosis, and this happened like a few weeks ago, maybe 4 or 5 weeks ago. So we started by having a clinical assessment, and then we performed the FEES. Okay, and this is what we found. So the advantage of FEES as well is that you can do that on different levels, on multi-levels. So the first level would be the level of the videopharyngeal valve. And as you can see, this is the palate and this is the posterior pharyngeal wall. These are the lateral pharyngeal walls. And I'm asking the patient to phonate A or E. And as you can see, there is this gap. There is videopharyngeal incompetence. As we move down to the level of the larynx and the level of the hypopharynx, as you can see, the pooling of the saliva. So it's really important to mention the level of the amount of secretions present in the piriforms or in the laryngeal inlet, as you can see. So I would say this really captured my eye. So we are moving more towards something on different levels, so I would not think about anything but a central problem. And then we started to administer different amounts of food and different volumes and different consistencies. And as you can see here, the amount of the residue at both the level of the piriforms and the base of the tongue and the vallecula, which indicates as well the weakness present in the pharynx and the weakness present in the tongue. So actually, we suspected myasthenia gravis, and we asked for a neurological consultation, and we tested for acetylcholine receptor antibody, which was detected, and the patient started the intake of mestinone and corticosteroids, as well as counseling for this patient. So as you can see, that this patient will not be receiving swallowing rehabilitation exercises. He will just be counseled about how to eat small frequent meals, take the largest meal early, and that he administers the food shortly after the mestinone intake, for example, within an hour. And to reduce the nasal regurgitation, we ask the patient to sit upright without tilting forward, as well as to limit the swallows to half spoons. And the patient reported maximum improvement. And as you can see, because he lives in a neighboring country, so he just had to travel. And so our take-home message for these cases is that not all cases will need swallowing rehabilitation. In this case of myasthenia gravis, swallowing exercises will make things even worse. So some will need medications, some will need surgical interventions, and this highlights the importance of our multidisciplinary team approach. So I think these are the all cases that I prepared for today. And before I end, I would like to take your questions. Our take-home messages for today will be that FEES and videofluoroscopy are gold standard instrumental assessment tools by which oropharyngeal dysphagia can be determined and the pathophysiology characterized. The goal of treatment is the safe and efficient oral intake for attaining and maintaining optimal nutrition and caloric needs. Multidisciplinary team is the key to efficient management of oropharyngeal dysphagia, and that there is no one size fits all. Decision making should be individualized and person-centered, and when coming to a decision, communication is the key between the members of the multidisciplinary team, the family, and the patient. And thank you so much.
Thank you very